health disparities and what is wrong with the current healthcare system in order to understand why, in fact, even PCOR was introduced into the healthcare arena. So Dr. Rebecca Johnson will be kindly presenting that session to you. She has been doing PCOR for past 10 years, since its inception, in fact. So much more adept in the methodology and exactly what makes the research different. And I'm learning a lot from her every single day. So with no further ado, I would just go over some of the core competencies. We have gone through it. We are continuing from yesterday. In fact, we would be starting to delve now into participatory research and patient-centered research from here on, inshallah. These are the skills that you would work with. Dr. Rebecca, why don't I let you take over from here? Thanks. Thank you. And I'll mute myself.
Okay, all right. Thank you so much, Fatima. Yeah. So we're continuing with some of the skills that we were sort of working with yesterday. So we wanted to give you, the knowledge which enables you to, sort of have the ability to provide for informal counselling and support. And that's why one of the reasons we're focusing a lot on access to care. And we'll go over a little bit of what we talked about yesterday. We know Beth, Fatima and I both know it's a lot, but I have to say we're really, really lucky. Well, I am learning a lot from Fatima, because I don't know any researcher who could have presented about the Medicare and Medicaid as succinctly as she did yesterday. So I thank her a lot, because all of it is very complicated. It's a maze, and I think if in my cynical mode, I think things are deliberately complicated to make them hard to access. But Fatima is very, very sort of much more upbeat about that. And that was really nice yesterday, where she was really saying there shouldn't be a situation where you can't have access to care. So we want to follow that through. Okay, so if we can have the next slide. Yeah, so we're moving through to help you improve your ability to participate in individual and community assessment, and that's why we're sort of wanting you to have a handle on asset mapping, because asset mapping will enable you to share knowledge with individuals, but it'll also give you hopefully it'll give you a confidence about the assets in your community which are available. But we don't want to paint too rosy a picture, as Fatima has just sort of indicated. So we do want you to understand the US health system and the social services system in all their warts and all, the good, the bad, and the not so good. And I think as we're moving through to Saturday, we want to sort of more explore more of the experiences that you've heard on the ground, because this is a mosque community, a mosque-focused project, and Dr. Padella is going to talk a lot about that he's going to take the reins on Monday and talk a lot more about that. But we need to sort of understand the general context, and then we need to try and pinpoint the specific issues which patients who are also members of mosque communities are experiencing regarding the health and social services system. And the reason why we want to involve you in doing that, and the relevance to research, is that you can then suggest questions and areas, and you can say, this is a really big area of concern for these patients who I work with. Okay, so we have the next slide. Thank you. So just to recap, just a little bit of a recap, because as Fatima, we've just got to keep this in mind all the time, that our aim is healthy communities. And what we mean by that is health outcomes, length of life, good length of life, length of life, good length of life, but also a quality, so a good length of life. And as we want to just remind you of this, because we're focusing on access to care at the moment, and because clinical care and access to care and the quality of care as well is in there too, is a key thing in terms of helping people to achieve both length of life and also good quality of life. And yesterday, Fatima did a great job of introducing you to the worry-free communities, the services really which the worry-free community provide, and the complexity of the navigation that they're faced with on a daily basis, that Fatima and the team are faced with on a daily basis. we will also, I want to sort of, we will move through to social and economic factors as well, because in some ways, as you can see, those are weighted more strongly than clinical care in terms of, achieving a healthy community. But for the moment, we're just really focusing on access to care, partly because Fatima has, one of the reasons why she wanted to bring you all together is because she will explain this much better than me, but the moment when the insurers press the button to let all that data through the system that she explained yesterday is approaching. And so we want you to be able to sort of witness this from the beginning of a year through, and really sort of pay attention to a year-long process of access to care, sort of from the beginning. So the timing is genius, and that's Fatima sort of set that up for you so that you can experience and see, and we can alert each other to things that are going on throughout the year with regard to access to care. Have a next slide. Okay, so you've got a lot of knowledge to process, and we've got a lot of terms as well, and I understand that, and I do apologise that PCORI has its own set of terms as well as everything else, and of course researchers and medicine has its own set as well. But I think we're getting there, and so I want to ask you just to use the chat function. I do apologise. I've just put something in the chat function, and I've realised I've sort of not copied that very well. So it's I'm sorry, a bit tired today. So if you use the fact that was actually to tell you that this month is October is Health Literacy Month. So it's also very relevant, and so understanding all these terms, it's a very appropriate time to actually think about that. So which of the following is classified by PCORI as a public stakeholder? Who would PCORI view as a public stakeholder? Would it be A, clinical researcher, B, worry-free community organisation, or C, MOS community? There's no right or wrong. Well, see what you think. See what you think with this one. So if you could just type in. Mm-hmm. Okay, thank you. So it could have been B or C, because a public stakeholder, as part of a research team, you have the researcher, and then the patients, patient partners, and many times public stakeholders. So that's the difference between the three. So it could have been, it's an organisation. The idea of a public stakeholder is an organisation. Others could have been policyholders, or so that just think of a research team as a conglomeration of different people from different organisations and with different setups and different institutional frameworks, as it were. So which of the following networks provides patient-centred information for community members living with chronic conditions? Oh, sorry. So the first one should be A. Is it A, creaky joints, B, CDRNs, or C, Healthy Heart, D, the Mood Network? So if you could send your answers, that would be awesome. Great. Fantastic. Okay. So yes, it was actually A, which is, I'm afraid, masquerading as B up there. So yes, so it was the creaky joints. The creaky joints arthritis power, the patient-powered research network, which Shilpa talked about yesterday for us, is a network which provides information for community members living with chronic conditions. And they define community as a community of patients. So if you come across patients who have arthritis, your people you're looking after or you're advising who have those chronic conditions that she showed yesterday, this site, this patient-powered research network, might be a good place for you to go to help understand a little bit more about what their life is like. What is it like living with these conditions, and what are the issues facing those patients? What is it that they really need help with? And also, if they've asked you questions, they will tell you as well. I mean, as Shilpa said, it's not about empowering. Many patients already know, they already manage their illnesses in their own way, but it's about helping and pointing to new resources which can help. Okay, so now just an open question. What determines whether a community member is or is not eligible for Medicare and Medicaid? Mm-hmm. Okay, thank you very much. Fatima, do you want to comment on those responses?
No, I have to go back to the other screen, so sorry.
That's all right.
Yes. In fact, correct. Residential status, income, household dependence, age, income, all of those are a factor. Income is definitely a factor, as well as residential status. Absolutely.
Good.
All of these are good. Definitely. Thank you. Thank you, guys.
Excellent.
Thank you. Thank you so much for throwing that in. It was nice.
Well, I know we had to deal with a lot of information yesterday, so I thought it might. Yeah, we just read it, and then we can sort of build on that. But that was great, guys. Thank you so much.
Thank you.
All right. All right. So the next slide. Can
you see the screen?
Yep. I can. Yes. Yeah, that means everyone can, doesn't it? Yeah. So the other thing we did a little bit before, I know this we've been doing a lot, but we also just sort of started sharing how to define the word community, wasn't it? And we were trying to find ways to describe a mosque community, and you very well, you all shared some really nice examples of how you might sort of move. You might go to different mosques for different things, or you might sort of you felt that there's a teen youth mental health group in certain places, so that you knew of things going on in mosques, and also, as yourselves, you seem to be quite mobile. So I thought that was very interesting. So you defined it through things like mobility, or sort of being part of a mosque community. And this is the definition that Dr. Padella has in the toolkit that he will that this project is disseminating, and which he will spend more time talking about on Monday. But I think this is really nice, because I think it brings together all the things that we were suggesting could help us define mosque community, and maybe you may feel that you'd like to add some more things. So please do add anything that you feel is missing. But I think this is a nice way, and this definition, certainly from a researcher perspective, will enable Fatah and myself and others to map out things for you, because Dr. Padella has a mosque community is identified geographically as a location centered by a mosque and accompanying ancillary institutions that are linked to the mosque. And it gives some examples. So Islamic schools, social services agencies, which, like Worry Free, I would think, health clinics, community halls, youth centres. So a mosque community thus represents all individuals who interact with one or more of these mosque-connected institutions. But that's the idea. It's a mosque-connected institution. And the reason why it's important to define this is it'll make it much easier for us to actually asset map with this, getting a sense of, because we can't asset map everything. But if we say it's mosque-connected institutions, people, networks, we can do that first layer, and then we can sort of decide as a group what other connections we want to make. So, as it says here, in geographically dense areas with large Muslim populations, mosque community members might live proximal to a mosque, but in more dispersed areas, individuals may travel significant distances. And that was definitely what you were sharing with us when we were talking about this. So I just wanted to sort of say that's to thank you for sort of helping to have that discussion and begin to sort of think about what this word, this term, this idea might be. And please let us, I hope, have a think about it. And on Monday, you can, I'm sure Dr. Padella will revisit this and think about sort of, does it capture it for you? Does it capture it well? Okay, can we have the next slide? So as Fatima said yesterday, what's very important for you as people who are sort of, navigators, helping people understand what the services are, it's very important to understand your patient. Now, Fatima, yesterday she had the slide saying, understand your patient. So today we're going to take it one step further and we're going to say, well, actually, what we want to do is understand your mosque community patient or community consumer, because we want to really understand what is it about being a member of a faith-based organisation, what are the things that impact the way people access services as well. So we're trying to bring the big picture and the more sort of the population, as it were, our mosque community patient consumers together, so that we can use the generic tools, but they will need to be adapted for a specific situation. Okay, and then we also want to think very much about not just coverage, but also lack of coverage, I think, and the barriers to care. So I just put this one up there because this is an example of the coverage of the Medicaid for autism services. And it shows you really that, for example, there are no fully automated implemented systems in Illinois, Texas, or New York. So there are whole areas of the states where there doesn't seem to be coverage for autism. So this is the type of issue that you might be coming across. Where are the services, and particularly if you've moved from another state and you're used to getting those services in a different state, you might sort of get a nasty shock when in Illinois that those things are not there. So I want you to think about what does coverage look like on the ground in your community? How are your consumers, friends, families, mosque communities experiencing the market, the good, the bad, and the ugly, and the barriers to accessing specific types of care in the community? And we will go back to this on Saturday. So if you can think about that between now and Saturday, and come on Saturday prepared to share some of these answers to these questions, that would be great. That would be really awesome. But in the meantime, Fatima is going to keep talking through the what the coverage is basically, and how you can and the access to it. Okay, so have the next slide, Fatima. So the other thing I wanted to show you was to give you a sense of the types of questions which research teams of organisations like Worry Free, researchers, community health workers like yourselves, other health professionals like ambulance, sort of paramedics, the types of questions that have come up and that PCORI has funded research teams to answer. And so again, each of these are actually links, so you can click on these and go back and sort of see them all. So they've tried to, and what's interesting is that mostly about transition. A lot of them are about transitional issues. So it's about, after hospital, what happens? A lot of people, they'll go into hospital, they'll come out, and then of course they're back to work, they're having to catch up because they've been ill, and they don't necessarily go back to the hospital for their checkups. So there's the transitional care services, and I work with older adults, and it's particularly an issue there. So if you've had a hip operation, I mean, it's funny actually, because this is one of the things that we share between the States and Britain. You have a hip operation, it's not at all clear how or where you're supposed to get home if you don't have somebody to, if you're not living with somebody or somebody to care for you. So these are all sort of projects that PCORI has funded, and the one they're using mobile integrated health and telehealth to support transitions of care amongst heart failure patients. The interesting thing about that one is they gave mobile health, mobile integrated health sort of basically mobiles to paramedics to help them and sort of help with heart failure patients. Okay, so have the next slide. So yes, but before Fatima carries on, I just want talking about the access to care. What I want you to begin to think about is I want you to think about the research. Sorry, can we go back a little bit, Fatima?
Oh, sure. I don't know how that happened. It's
okay. That's okay. That's right. It's like sometimes. I know. So what we just wanted to do. So we introduced talking about the research team. So that's led by the researcher committed to interdisciplinary teams, which include patient and public stakeholders like Worry Free or the MOS community. And what they will do is they will engage in project processes and research steps. Okay, so let's have a look at what it looks like and where you can come in. So the what, when, and how to engage is this bit. So the who, you are the who. The who is who gets engaged in research. What we just said, the researchers, the public stakeholders, the patients, and yes, those groups, and whoever else needs to be at the table. What do? Well, they sort of they may have an idea themselves, and you know, studies that you met were in talking to patients of all ages. I mean, I talk to mostly older adults over 65, so I get a good sense of their life experience and the health conditions that they live with on a daily basis, the multiple health conditions they live on a daily basis, and how difficult it is to access home care, sort of how to actually sort of keep going with conditions like Alzheimer's and dementia. And so you get a good sense. That's why you're so valuable. You're on the ground, you're talking to people, you're observing all the time. You really understand the lived experience of this big picture that that Fatima's been painting for you, this big healthcare picture. And so, yes, studies that matter to patients, and the goal is to provide useful information to influence others and to obviously impact health decisions, healthcare, and health outcomes. So remember that health outcomes are quality of life and length of life. That's what we're going for. So next slide. Okay, so
very rich slide. There's a lot.
I know. It's a good slide.
Yeah. Wow.
Yeah. Yes. So yeah, do drop any questions. Do drop them in the text. We're going to have a little pause in a moment. So yes, and what we'll learn more about on Saturday is the principles. So Corey has a whole set of principles, engagement principles. These are trust, honesty, co-learning, transparency, reciprocal relationships, which means reciprocal means it's almost equitable. It's you know, it's not one person telling another what to do. There's an equality about it, partnership and respect, all of which are just fundamental to working with people who have lived experience, which we need to respect everybody's lived experience. So what we will talk more about on Saturdays, we'll talk a little bit about those principles. And you've already getting a sense, I'm hoping, you're getting some of these foundational elements. So you're getting an awareness of the methods that Pathora uses. You're aware that they're valuing the patient, that they got we're looking for ways for patients and researchers to partner. We're identifying resources and infrastructures, policies and governments. So we're doing all of those foundational elements at the moment. And we're going to try and move you through to some actions where you can actually feel confident when you go and make those connections with the mosques, with the key stakeholders in the mosques. So that's what we're trying to move you through to now. If you have the next slide. Okay, so Dr. Padella summarizes a study phase very well, I think, because he's gotten up with three simple phases. There's the planning phase, there's the conducting phase, and there's the disseminating phase. And we are all engaged at the moment in the planning phase. So if you can see there, this is the moment when researchers and patients and organizations come together and they decide the topic of interest. And you can do that, you identify that through the policy reports, the media, or the research data, all of those sources that we have been touching on and looking at. Or you can do your own focus group surveys or needs assessments. And I can talk through what a focus group is, but it's also, in many ways, it's a group discussion, and there are lots of different ways of doing group discussions. But that is if you're feeling that you're moving towards really feeling very passionately, or in many cases, obviously angry, because it's not always often people are driven by a passion to change things. So, and that you feel that this is a topic that the community wants to explore. So, like transition of care or access to mental health services. So these might be things that you want to sort of talk about, or you could have support. You could have, you might find talking in your mosques that there's a sort of, that you do a needs assessment or a survey, or just through talking, actually, often just picking up ideas. You might want to sort of do just see whether people would be interested in an exercise program or a sort of dementia sort of support group. So it's finding the topics that matter to the community, which are coming up. That's where we're at the moment. We're planning. We're trying to find out what the topics of interest might be for mosque communities. Okay, if you have the next slide. Okay, so I just wanted to give you an idea. So here's Dr. I was trying to make these 3 different colours, but so the first 2, you can see Dr. Padella's 3 stages. So you've got initiation, conducting, and disseminating. And what this graph shows you is it shows you that most partnerships, most research engagement is around the actual doing of the research. That's the conducting. And the initiation, this is when researchers get together to identify questions and research topics. That's not as much, and the disseminating is not as much. And that, I think, is interesting, because I would like to see researchers do a little bit more of the beginning, asking communities what the issues are. But I just wanted to give you an idea. So there's the moment people, it's conducting the research that is the most prevalent activity. Okay, next slide. Okay, so we're moving towards collecting tools. We're moving back towards the community, so that we're really trying to understand access to care and how you beginning to think about what the issues are experienced by mosque community consumers of health. Okay, so next slide. And there are processes to go with this, in that, and again, Dr. Padella will say a little bit more about this, but you can see here it's initiation, planning, implementation, monitoring, and then closing. So, but we're very much in this initiation stage at the moment. We haven't quite got to the planning, but I know Fatima has some great tools for planning, so we will be able to share those. But at this point, I'm really wanting you to think about what sorts of topics do you think are important? Okay, next slide. Okay, and so we will, on Saturday, we will look a little bit more at the standards for research teams and also the behaviours and the principles. Okay, next slide. Okay, so, and so we have talked about underserved and underrepresented patients. I hope you feel that you're beginning to get a sense of what those words mean and who those people are, who you, we've sort of, the public partners, we've got a good sense of those, that they're communities and organisations supporting patients. But it's not just patients. We're particularly interested in patients who are part of mosque communities and who often have who are not necessarily American citizens, but have, and we know from the data that we've already looked at, that when people come into, that people, Fatima's phrase, we don't have residential status, so there's a different issues in terms of access to care. And the community asset mapping, I will give you at the end a sort of sheet, because I would like you to start listing which community asset, what are assets that you've heard that we've introduced you to that you think will be useful to you and your mosque community and the mosque community that you're part of. So I think I think the next slide is
Okay.
Yeah. So if we perhaps just pause for a few moments.
Sure.
Do you have any questions? Anybody have any questions, or just want to take a little sort of deep breath, sort of hold for 5? Would anyone like to, I mean, your perspectives, would anyone like to share, sort of anecdotally what the experience is that members of your mosque communities are having with the healthcare system?
I can share a little bit of what I'm seeing through food pantries at the mosque communities that I work with.
Great.
So I am assigned to 2 like mosque food pantries on like the south side of Chicago, and I have a couple of site visits scheduled for the next week, and what I'm typically seeing in the results and the numbers is that more people are coming out. How the Greater Chicago Food Depository works is like no services are supposed to be held within a 30-minute, but it's really nice to see like the communities coming together, and especially just the variety of people that are coming together. So one of the things we're hoping for is how to make those partners more successful in like health referrals, helping folks apply for SNAP or Medicaid or Medicare, and how to build up those partner pantries in those communities in order to be full encompassing to the communities. So it's really nice because a lot of people do have, especially now during COVID, like the requests in our like need food line or benefits team have gone up almost like 50%, and people need help with these applications. So we're trying to do SNAP-O training with them. I have like 2 communities that are very impactful in like Chicago Lawn and near Hyde Park, where we're trying to get their volunteers trained in SNAP-O, where they can enroll people in SNAP benefits. So people are coming out, and it's nice to see.
That's a great example. That's really good. And I love the way that you sort of, it's food pantries which are leading to sort of a greater access to care. And so it's people's awareness that's really the way it all fits together is like a jigsaw. Yeah, that's a wonderful example. And also helping. So what was that acronym? What did the acronym stand for? NAP.
SNAP-O. So it's for like SNAP benefits, but it's a volunteer-based enrollment where volunteers, they don't get paid by anything, but they provide a social service. So it's like we're still trying to figure out how to schedule trainings for partners, but it's basically just a volunteer team that helps submit, that is qualified and certified to submit a benefits application in. So that's what we're trying to like push on pantry partners that are fully capable, and if they have the volunteer staff. But this would be something I'm interested in as like a community health worker, because it would be something like a really good training for a community health worker to have to help enroll folks.
Yeah. Oh, that's cool. That's really cool.
Yeah. Thank you. That would be a great service, Andy. That definitely, there is a lot of need for it. A lot of people during this time of the year, even though people can apply for Medicaid at any point in the year, it is unless they go through the marketplace, and they are denied, or their application directly goes to Medicaid, actually, Medicaid system. So that's almost a sure shot Medicaid acceptance right there. And especially if they are below a certain poverty level, you can directly go into the Medicaid system and enroll them. So there are the eligibility requirements, and there are validation for the income requirements that are there, and a lot of people um, don't understand that very well. But if you have a training set up like that, and you can train some volunteers to do it, that's a great help. That's amazing. In fact, we have one of the Jay's Jimmy. Maybe perhaps we can connect you to Andy by sometime later this week or next week, and we can have some kind of a connection out there, because they're out there by 65th, I believe, and about 10 miles exactly west of the Museum of Science and Industry. And it's not, it is still within the range, and there are quite a need out there too, definitely. So I'm going to move back to going back to from PCORI's standards, and once again we've transitioned into serving people, and why does it matter where the people are coming from, and where they're going in terms of healthcare coverage. So we have all of these different options. We have Department of Family Services, which is Medicaid. We have All Kids program. Now, All Kids and Medicaid All Kids is actually retired, but it is all together with Medicaid and CHIP now. But it used to be there just up until last year, I believe. But original or traditional Medicaid has kind of taken over, and you can not traditional in the sense that the state would provide, but Medicaid has gone managed care. So let me actually explain it a little bit later, because the slides are coming up. So there is Medicaid, there's All Kids, there's healthcare.gov, that's the marketplace applications program. There's Medicare, there is again CMS.gov, which is this looks over the Medicare Advantage plans. So all of these combined together, it's confusing as where would the person would go if they don't exactly know where they can go. So why does it matter? Because it matters what is the in-network and out-of-network medical care for them. So, for example, any one of these people have a particular doctor they need to go to. They need to be looking into the network that the doctor is in. So, this is an example of a network model, and pretty much all the networks these days come under ACOs, which is accountable care organizations. Now, we do have ACOs, and then we also have the payer systems. So payer systems meaning you have Medicaid, you have Medicare, you've got Marketplace, and within Marketplace you have different payers like Blue Cross or Ambetter or Aetna Better Health or United. They actually have primarily private plans or employer plans. They don't have a marketplace plan. But when it comes down to the networks, all of these have their own networks, and every plan can have multiple networks within it. But one particular doctor may not reside in multiple networks. They may only belong to one network, or they may belong to different parts of the network, but different networks, but different networks, they may have different privileges. So it all depends on the network benefits and where the patient has their benefits residing. For example, if their benefits are, or this beneficiary, that's the term for the consumer in the insurance market. So where this beneficiary has their main benefits, or where the benefits are being paid from. That's the key word there. So let's take a look at Medicaid plans. Now we know where we have different buckets or different categories, like Medicaid, marketplace and healthcare plans, private insurance healthcare plans. These are the payer sources, for example, federal government, state, county, private health, or employer plans. So going back, in Medicaid, you actually can see, thank you, Dr. Rebecca, for the slide. It actually helped me quite a bit getting the different plans together. So if you look at it, there is a green dot in the Cook County. And then you have these orange stars in different counties in different parts of Illinois. Now, what does really that mean? This means that not every insurance is going to be available in every county. Okay, so for example, you have Medicaid, but Medicaid is actually governed by managed care. Now, what does it mean by managed care? Which means that Medicaid actually pays the insurance companies to take care of the beneficiaries. So, for example, if you look into the orange dot or orange star list, you can see Aetna Better Health. You can see Blue Cross Community, Humana Health Plan, Illini Care, Meridian Complete, and Molina Healthcare. 1, 2, 3, 4, 5, 6. There are 6 different insurance companies that are actually taking care of the Medicaid patients in those particular counties. So that's what this particular, the managed care means. So traditional Medicaid, which is run by the state, that Medicaid doesn't reside in the counties where there's an orange star. What resides in those counties are basically insurance companies that are taking care of Medicaid patients. Now, why would Medicaid do that? Mainly because taking care of a population comes with a burden of case management. And as we have seen, that the socioeconomic factors, the transitional care, there is care within the network or out of network. The patient may go to see a provider that doesn't reside within the network, and that actually cost Medicaid a lot of money. So Medicaid doesn't want to pay it. So all of these case management issues that arise, Medicaid, the Department of Health and Human Services within the state of Illinois, may not have the bandwidth or the manpower to take care of all the Medicaid patients that are residing in all the counties throughout Illinois. So what they do is they actually say to Blue Cross, or they picked out these 6 insurance companies and they told them, listen, we have 20 million people residing in these counties. Here is a $50 million budget. We need you to take care of these people in these counties. And here is what we are allocating you to take care of the 25% of the population. And so now insurance companies get that entire piece of the population or communities where the care needs to be managed. And that's the concept of managed care. So pretty much the entire country will be going managed care very soon. If we're almost getting there with everything. There is some barriers to it. Whether it's good or bad, it's yet to be seen, honestly. There's going to be definitely there are going to be pros and cons, as with any system you put in place. However, one of the things where people say that, oh, now I need a referral for everything. Oh, now I have to take the permission from my case manager to go to a therapist. And so the case manager reviews the case. The case manager says you are allowed 6 therapies sessions or 6 weeks of therapy sessions, which comes out to be 12 sessions. And that's what you are approved for. So if you want to get more more therapies approved, you have to go back to the case manager who would approve it per the doctor's permission. So that's the entire thing that goes with the case management. And with Medicaid, this is what's happening. So we can see that there are going to be barriers to access to care when the Medicaid actually with these particular patients, because now they have to go through the managed care folks, people who are managing their care. So, and not necessarily it is going to be timely. So that's some of the gaps we would need to fill in. Now with the Cook County, with that green dot, what that is, it's very interesting. And there are few cities in the entire country, that actually have it. So the city of Chicago gets its own funding from the state and some from the federal government as well, to actually manage the health of the people within the city of Chicago, because it's actually a metropolitan city. Not only that Chicago is a metropolitan city, Chicago is also a sanctuary city. So sanctuary cities are those cities where they shelter the undocumented or the people without residency status. Now, what does that mean is, if that person goes to the emergency room at Cook County or any of the hospitals within the city of Chicago, then they cannot be asking them, where are you? Where's your paperwork? Who's going to pay for you? They got to provide medical care to that person. That person needs follow-up appointment. That person will be going to the same provider or same network. So city of Chicago actually took the money from Medicaid and from the federal government, and they floated their own plan to bring everything under managed care umbrella. And that plan is called, there are actually two plans. One of them is called County Care. The other one is called Next Level. So both are between the two of these plans, these plans are managed by the Chicago Department of Public Health. And therefore, all the care that goes through the case management, everything that their care is balanced under the underserved population's care is balanced under these two plans in the city of Chicago. That's what happens. So these are the different kinds of payers, as you can see. So there are the payer sources there is federal government. There are payers under the federal government. There are payers under the state. There are payers under counties. There are payers for private health insurance. There are payers for employer plans. And then there are payers for the affordable care plans. Now, because of these discrepancies in different payer sources, there are systemic factors that are leading to the disparities. See how if everyone is providing the same amount of care, they are doing the same case management. If they are not distinguishing between who gets what kind of service, there are no health disparities. However, because of all these different payer sources, the system inherently is set up to create a health disparity. That's where the problem, in my opinion, I'm sure there are people who disagree with that. That's where these are occurring. And that's why we say that there are social and economic factors. It's 40% of that. Education, employment, income. Income is a big factor of who accesses what kind of care. See how it's coming into the family and social support, community safety, employment. So for example, if you work for the railroad, you get let's go further. If you work for the railroad, the federal government has a railroad plan, the RR. So your care comes from that, or that plan pays for your care. So whichever network accepts that railroad care, you will actually go to that network. You cannot go to network outside that. So likewise, VA, there are VA hospitals that are set up, and they come under scrutiny quite a bit because the kind of care that's delivered and because the way care is delayed in there. Federally qualified healthcare centers, 20% of the budget for every federally qualified healthcare center comes from federal government. It comes from federal government. That's why they are federally qualified. So why they are there? Because these kind of federal funding actually takes care of the people that are out of a status or people that fall into these pockets where they cannot be insured. So federal government has allocated the funds, not per capita, but they give lump sum money that here is, $2 million for this particular, for example, Heartland Health Centers. They get X amount of $1 million just because that they take care of a large out of a status resident population. So, see how all of these things are tying back into the social and economic factors, and the income is a big variable into health disparities. So where does my healthcare fits in, right? So this is in a nutshell. Of course, the yellow is a state plan, the reddish is the county plan, thanks for the discussion, Dr. Rebecca. This is what I came up with. I was like, oh, this is great. So, there are 350 million people. That's the total population approximately. Now you divide them up into two groups, the people who are insurable and the people who are uninsurable. So there are about approximately 10 million people. Those are the only people out of 350 million that are uninsurable. But even for the uninsurables, there are county plans, there are federally qualified healthcare centers. And for the insurables, you've got all of these different options that are right in front of you. So that is why I say that there is no reason why anybody would be left uninsured in this country. There is no reason for it. For the insurables, now you can divvy them up into three different classes. We say that the people who are greater than 65 years of age, the people who are 18 years, between 18 and 65, or 18 and 364 days. And then there are people who are under 18 years of age. So the people who are greater than 65, you got actually 4 different kinds of choices. And it depends which bucket they go to directly on their income. So whatever they earn, actually, because of their income, they are placed into one or the other buckets. That's what's happening. And likewise, the same thing with 18 to 65, people based on their income then fall into a particular category. And the population for the under 65, again, they fall in the similar categories for those people as well. By the way, in the under 18, I didn't put the employee health, but kids whose parents are actually have the employer insurance, they are automatically insured by the parent's employer. Okay. So for the 65 and over, you've got Medicare, original Medicare and supplemental. You got Medicare Advantage, Medicare, Medicaid, MMAI, Medicare, Medicaid Initiative. Why is that called an initiative? Because it is again, managed care and the county plans. So for the population 18 to 65, you got marketplace, you got employer, you got traditional Medicaid, you got county plan. And likewise, okay, so let's move on. So federal government, you actually have Medicare, VA, Veterans Affairs, Railroad, and federally qualified. I'm sure there are other smaller buckets that are out there that I have not listed here. These are the major ones. The state actually does 2 plans. There's Medicaid and CHIP. County plans, pretty much not every county. There are few counties that have the county plans. Now, Cook County, we know they have county care and next level. In DuPage County, we have Access DuPage. Now, in Will County, there is no plans and county plans, but Will County is one of the needy area where there really needs to have a county plan, but it is not even in sight. and the lawmakers are really not doing anything about it. But Will County has a lot of opportunities. It is a resource-rich area, and it has become a resource-rich area in the last 10 years. So really, that county should be floating out a plan. There is no reason why they haven't yet. And that's where, part of advocacy comes in, where once you recognize that, wow, this county is rich and they have all of these resources, why aren't they taking care of their needy population? You can actually ask for that and do something about it as a community health researcher or a community health worker. So private health insurance plans, again, these are commercial plans in the private health. Now, one of the things I got to tell you about in this particular slide is that, see how if a person is over 65, they have these 4 different options. Now, if they go to a person who provides them or who enrolls them in original Medicare or supplemental, they may not know how to do a Medicare Advantage plans. In fact, the green bucket that you see right out here is actually commercial plans. So all of these blue, green, red, and yellow, they actually requires a special training, like what Andy was telling me, that Andy was telling us that there is a training going on for SNAPOV. Likewise, there are trainings as well as certifications for almost every single one of them. And every bucket has a different certification and a different training requirements or a training modules or training program. So the person who is doing a healthcare coverage, you really need about 12 different people here to be working with 12 different kinds of things. But luckily, what happens is if a person who's doing Medicaid, they're at least give you help with all the different kinds of Medicaid options. But again, Medicare, Medicaid, MMAI is a technical area, and so the person who is doing traditional Medicaid for the kids or the adult population, they may not be able to help you with Medicare, Medicaid, elderly MMAI plans. So this is why it becomes difficult for people to get to the right person, or that right person to have all the options available to you. So that's part of the reason why all of you, every one of your help is needed, so that we can educate people in health literacy. Now, commercial and private health plans, both employer and health plans, they are, we talked about HMOs and PPOs, and then Affordable Care Act marketplace plans, they come with essential health benefits. That's another source. And there are mainly about 5 or 6 total insurance companies that float the plans on the marketplace. And that's one of the battles that we are in, that these essential health benefits are a mandate under ACA, that the insurance companies who are providing these essential health benefits are the only ones that can sell the plans on the marketplace. Otherwise, they're unable to market their products. Okay. So a little knowledge check at this point, but let's breathe.
Actually, first of all, I just have a question. Can anyone take the training, or do you have to have a certain level of qualifications to sign up?
Anyone can take that. Well, here's the thing, though. The thing with the marketplace is that you have to be under a CDO, certified designated organization, and that's when you can take the training. But so there, and again, with Medicaid training is not readily available. But here's a resource, Health Reform Basics. And I think when we get to the assets, I would put it on there as one of the biggest assets in these trainings. They're putting out materials that really helps in training people. So you can do the trainings and provide the services to your own community, but make sure that you are under an umbrella of a particular any of the nonprofits, because it does, so as long as you are covered under a nonprofit, you should be good.
Yeah. Okay.
Yeah. Okay. What is the advanced premium tax credit, guys? Anybody remembers? A, B, or C? It's a tax credit that you take in advance from IRS to cover the total cost of your health insurance premiums. This amount is based on your projected annual income. It's a tax credit that you take in advance from IRS to support your kids and family for family food cost because of low income. Or it's a tax credit that you take in advance from IRS for the previous year's medical bills. So let me see what I have in the chat box. Okay, very good. Thank you. Thank you guys for the great feedback there. That is correct. A is the right answer. A tax credit that you take in advance from IRS that covers the advance payments. So now we come to the health coverage from basically from the marketplace. And once again, it should be the review at this point. The US citizens people who are eligible to be citizens, which means they have resided in this country for 5 years and they're eligible for citizenship. They can get the ACA, they can get the ACA coverage, they can get Medicaid, they can get Medicare, they also can get employer coverage. Now for Medicare, if they have not completed 40 quarters, they probably will have to pay for it. So you have to, this gets a little tricky for the people who are citizen, but they have not worked in this country. So we're not going to go into that details because there's a very small population of that. If you find somebody, you can recommend them to the right resource within the assets. The new immigrants, less than 5 years, they can get advanced premium tax credits and they can get ACA. Their kids actually go to Medicaid automatically. And this is a particular immigrants who do not meet the requirements, even up to 138%. They cannot get Medicaid. However, we have seen their premiums as low as $0 on the marketplace. And their insurance comes out to be very, very cheap. Remember that cost sharing reductions. So they get maybe $250 altogether in the out-of-pocket expenses or in deductibles, but they get a very good deal on the marketplace. Where they have new immigrants that are not working, then their sponsor's income actually comes into play. So it depends upon what their income is, and based on their income, they can get the advanced tax credits and the ACA. And the visiting visas, that we get a lot of people actually that request us that can we get the marketplace healthcare coverage while we're on a visiting visa. Unfortunately, those people cannot get ACA, but they can get private health insurance, by the way, a temporary plan. And out-of-status residents definitely should go to county plans and the federally qualified healthcare clinics. Now, who pays and how much do they pay? That's always a question that sometimes people say that, why is my Medicare costing me so much? I thought Medicare was supposed to be free. Not yet. That's where we are going, but not yet. So the federal programs actually don't have any income limits. The state programs and the county level programs would actually are for low income and less than 138% of the federal poverty level. The income-based program or the income programs are the ones that are private insurance plans, employer plans, and ACA marketplace plans. So how much do the plans pay and how much does the beneficiary pays? These I've put it in the comparisons just to give you a rough idea. The state, if you see, Medicaid has a full coverage. However, they pay very often we see that now actually Medicaid in the last couple years, Medicaid has started to do. They actually pay about, or they cost maybe the needles for the insulin or some kind of prescription drugs. They would cost $3.98, and the drug could may be costing them $200. So but in total they're going to come out to be less than 1% in their total cost, and that usually goes towards the medication mainly. Now, Medicaid for the elderly actually has two plans, which is QIMBY and SlimBy, that also pays less than, they would also pay less than 1%. Medicaid, people think that Medicaid is completely free. Medicaid full coverage is completely free. However, the Medicaid, some people who are at 138% of the FPL or 140% of the FPL actually, so they are not qualified, but their kids do qualify for Medicaid, and they may end up paying $20 per child, but they will pay no more than $80 per month, depending on how much they make. But Medicare, if you see that Medicare Advantage, Medicare actually pays about 80% only. It doesn't pay completely for the older people. So they would pay 20% out of their pocket. This $150 plus drug cost, or it's actually plus, because then they would have to buy a supplemental insurance, and that supplemental insurance starts actually from 150 and goes on all the way up to $600-700 per month. So plus they would have to buy a drug plan. So the elderly care can cost quite a bit. But if you go to the Medicare Advantage, this cost actually comes out to be relatively cheaper. So this is a huge advantage for the elderly people if they want to get into Medicare Advantage program, which is the Medicare Choice C or Part C. That's what we call it. Okay. So with all of these different choices that we have, the very first question it comes to our mind is that, can government or state pay for my health insurance? What would it take me to get Medicaid? That's the question that we very often get from many people. Once again, residency status, age, income, and assets. In assets, it's an interesting test that Medicaid recipients have to pass an asset test. That's what they call it. So which means that they cannot have a rental property, even if they are losing on the rental property. If it is a rental property, then it's taken as a not, but it may make them not eligible for Medicaid unless they can show the proof that they cannot get rid of the property and it's actually a liability on them. So, but again, there's paperwork that goes with it, and the case manager or whoever is processing the Medicaid application would have to process the paperwork for them. But their cash assets should be less than $17,000. Asset test, again, own a house where you live. This is an interesting. It doesn't matter what kind of a house you live in, as long as your income is 38% or less, Medicaid is applicable for you. You can be living in $1 million home and you can get Medicaid. It's interesting. So it doesn't matter what kind of a house you have. What matters is, what is your income? But you cannot have a rental property either. So if you have a rental property, it's disqualified. You got retirement plans, you get disqualified. You have 401ks, you're disqualified. You've got a bank balance, you're disqualified. That's the problem. It's interesting thing with bank balance, even though they say that it's $17,000, but if you have $200 worth of money sitting around, we have seen that the HFS comes back and say that, oh, there is a spend down of $200. So till that person spends that $200 in their bank account, they are not qualified, or Medicaid doesn't start to pay. So there's a little bummer there, but very often they bypass that. And that's abe.illinois.gov, and anybody can actually start their own application. As long as you're doing your own application, you don't need anybody's help. However, you need to know what the right answers are, and what are the answers you furnish must have a proof associated with it as well. So at abe.illinois.gov, if you go there, you can actually have all of these different types of applications that you can apply. The SNAP, it's actually not just Medicaid only. Along with Medicaid, you can apply for several other benefits. You can apply for Supplemental Nutritional Assistance Program. That's the SNAP, now formerly food stamps. What Andy was talking about is SNAP-OV. It's actually SNAP, but with the facilitation of volunteers. So SNAP is actually the state-based program, and SNAP-OV is actually one of the derivatives of this program that the organization is working on. But the volunteers are helping people fill out this particular application. Cash assistance, and again, in some cases, the state does provide cash assistance to people who are really in need. Temporary assistance for needy families, TANF, uh, and then that's the refugee repatriate assistance. These are TANF, AABD, and RRA are the cash assistance programs actually. Medical assistance, this is the Medicaid program that we are talking about. And then you have Medicare Savings Program. This is where you apply for the elderly, where you can actually. But unfortunately, abe.illinois.gov does not have a training program that you can go ahead and get trained on. But there are other places like Health Basics Reform, you can get some kind of training on there. But these applications are relatively easy. If you have a straightforward case, it's not that difficult to fill out, but it just takes some experience and some knowledge of what the right answers are, definitely. Another thing I wanted to point out to people is that Medicaid actually pays 3 months prior bills. So for example, if I apply for a Medicaid for somebody for Medicaid today, and this person gets approved for Medicaid, Medicaid will take care of the 90 days worth of prior bills from today's date. It could be medical inpatient, it could be dental vision services, they could be prescription drugs, health hospitalization. So that's the best part about Medicaid, because they actually, they can, you can go back, and Medicaid is the only payer who would do that. Not even Medicare does. So Medicaid and students, a lot of the students actually, if you have a proof of education, you can get Medicaid assistance very easily. And you can fill out your own applications and support that. Again, access to care, we've gone through, as just a review, we have actually gone through most of these 3 categories. And hopefully by now, these 3 buckets are relatively, or 4 buckets are relatively clear to you as to which person fits into which category of the program. Again, it happens is that the people who are immigrants, especially less than 5 years, it is very difficult and very hard for them to understand the landscape. Not everything is clear. Sometimes they are living with so-and-so. And one of the biggest question is that, what is your household income? And they think that everybody in the house needs to provide their income as a proof, and they never even bother to apply. Household income means just the income that goes on their taxes. That's it. You don't have to furnish anybody else's income. But again, the way the questions are set up in the forms on the websites, it is confusing. Okay, so I don't. I at this point, I want to open up for people to ask questions and see if things are clear. What do they want to review?
So I had a question about managed care.
Mm-hmm.
So you said the county gives the money to the insurance company and they just take care of everything, or like does the county just oversee how they're implementing it, or what happens exactly?
Mm-hmm. Correct. So basically what happens is managed care is actually a word where care is being managed. That's what all it means. So it is a term, it is very heavily used in the insurance industry, and insurance companies actually, for example, you may hear that, here's a good example. So a person who, let me go back to this particular slide. So Medicaid actually has these plans in there, right? Aetna Better Health, Blue Cross Community, Illini Blue Care. Blue Cross Community, or here, the statewide health, in the teal color, where you have Blue Cross Community Health Plan. This is one of the most famous plan that's out there with the Medicaid recipients. Now, what happens is this particular plan can only take care of, let's say, 10 million people. Now, there are a lot more than 10 million people in the state of Illinois. So every year, the Medicaid asks people to renew their coverage. Now, some people can renew, their coverage is renewed in February, some people's coverage is renewed in July, and some people's coverage is renewed in October. So what happens is if they come in July or October, they had a Blue Cross Community Health Plan, but when they renew their coverage, they come back and they say that, oh, we cannot give you the same plan, Blue Cross, because that plan is no longer accepting any new people. But how am I the new person? I just had that plan. Guess what? During the time of your redetermination, that plan became full and they are no longer accepting members in that plan. And they are because that plan is capped out at 10 million people. For 10 million people, the government may have given them $40 million to say that, this is the $40 million. I want you to take care of 10 million beneficiaries in the state of Illinois, and you need to manage their care. And that's where the word managed care comes in. So the Blue Cross, what they do is they have case managers sitting at maybe, perhaps 500 people or 1,000 people. And those 500 people and 1,000 people, there is one case manager over it, and they are managing their care. So most often younger people or people that do not have pre-existing conditions, they go to the doctor once or get their basic test done. They don't need to have their care managed. So their care will probably cost about $200 or $300 for the whole year because they really haven't used their care. So those dollars, per capita dollars, now gets put on to the person who actually needs higher acuity care. So they kind of shift the dollars to the ones that needs more care, but essentially, all of those 10 million people gets their care managed by these 40 million worth of US dollars. Is that clear now?
Yes, thank you.
You're welcome.
Okay, so I have a question. Okay, so let's say I live in DuPage County and I'm getting the county coverage. So am I also getting the federal and state coverage, or is that different? Do I have to sign up for that differently?
No. So basically, if you are DuPage County has a county plan called Access DuPage. Now with Access DuPage, you can get enrolled, and it is delivered, or it is networked in Central DuPage Hospital primarily. So anything that comes under the Accountable Care Organization of Central DuPage Hospital, which is actually Northwestern, by the way, your care would be managed by them primarily. So you can go to a doctor that is within that Accountable Care Organization of Northwestern. And in fact, Blue Cross picks up the tab for that particular person. So Blue Cross Blue Cross really is donating to the Northwestern to take care of those patients, or they donate through the county. So that's how that particular county plan is done. So you're not getting federal aid, you're not getting state aid, your county is taking care of those. County dollars are coming in through the state, but from the Blue Cross. That's what's happening there. So the monies are being channeled through the state programs, actually.
Okay, so what happens if I move out of DuPage County?
Yes, so you would actually lose your DuPage County plan. You would no longer, since you only get the benefit of that plan as long as you live in that county. And likewise for the Cook County people, the county care or the next level plan, they only have that plan as long as they reside in Cook County. If they don't reside in Cook County, they're not eligible for that plan, because it's only for the beneficiaries. That's what the managed care means, that you go to the network, go to the particular network, and you live in that area. So it's by geographic area.
All right, thank you.
Good questions. These are all beautiful questions and extremely useful when you go out and provide the outreach to people, or when you are doing your asset mapping. Absolutely. Any other questions, guys? Any questions on Medicare?
Just one question actually, Fatima. What do you think the impact of COVID is having on insurance?
Yeah, so that's I was just listening to NPR today, and they were talking about that the COVID-related the insurance cost is yet to be calculated, and in fact, and the way I see it is that many people actually have pitched in because COVID is literally grasping resources from anywhere it can get. So the county plans are coming up with these. Somebody is paying for these tests in essentially, and these are coming from different buckets. So a lot of the times people are essentially the entire healthcare system is picking up the cost of COVID because there are federal dollars for the COVID testing. There are insurance companies have allocated the dollars for the testing because they want to keep their population healthy. But one of the things that we have come across with is that people go to the ER and they didn't have COVID. So that ER visit was not covered under the COVID umbrella. So if this is a person who doesn't carry health insurance, they are now getting this, big, huge bills. They are accruing these ER bills from the hospital because the hospital said that, well, you don't have COVID, so I can't bill the federal government for your visit. So that's where we have seen. And then there is another discrepancy or not discrepancy, it's kind of a price tag that the healthcare providers are adding to. Under the umbrella of COVID, they are ending up doing other tests, for example, for STD or for flu, influenza, or those kind of tests because they want to rule out some of the other things. So yes, the COVID test is covered by the federal government and under the pandemic dollars, but the other tests are not covered. So they need to make sure that they have health insurance or their health insurance bills them, or the provider bills their health insurance. So if they did not give them an insurance card, then expect to get a bill that is not COVID related bill. So all it takes is within 30 days, make sure that provider has your insurance card. And it's as simple as that. Okay, so anybody else? Are people clear with Medicare, by the way?
Assalamu alaikum. I have a question, if you don't mind.
Sure, what's up?
It's about Medicare Advantage. So it says here the beneficiary pays from 0 to 12,000. I think that's a wide range. So how do they decide how much he's going to?
Okay, perfect. Okay, so let me actually get you guys over to this particular slide. So in the original Medicare, a person is eligible for Medicare Part A if they work in this country for 10 years. 10 full-time employment will actually qualifies for a free Medicare Part A. Medicare Part A today costs about $450. So if people can buy these days, actually the immigrants actually are getting letters from CMS saying that you may be eligible for Medicare. So if you are interested to enroll in Medicare, go to the Social Security and enroll. They are going and enrolling into the Social Security, and guess what? They are now getting a bill of $458 some dollars. Actually, that's what it is for Medicare Part A. So they're like, what is this? And they come to us with the bill saying that, why am I getting a bill? I thought this is free. Well, it is free for those people who have worked in this country for 10 years because they have paid into that Medicare fund. So, and Medicare Part B actually cost, no matter whether you have worked or you have not worked, it doesn't matter. Medicare Part B will cost about $150 some. So Part B, there's a cost, and Part D, there's a cost to it. So Part D is the prescription drug coverage, and that many insurance companies offer that. So you can actually go to the Blue Cross, United, or Aetna, or Illini, or Molina. You can buy into the prescription Part D. So if you add these costs up, plus you have to add the Medicare supplemental, which is the 20%. So even though you are covered for Part A only covers 80%. So you have paid into the Medicare insurance, but now you have a coverage for hospital or any inpatient facility, which includes nursing homes, rehabilitation services, home health care, all of those things. You have 80% of the coverage. What happens to the 20%? Now, the 20%, you have to buy a supplemental insurance. So all in all, this entire thing can cost anybody from $150 to about, $700, $800. We actually had a client that was paying $1,200 in Medicare monthly payments, and we actually brought that client down to about $108 a month. They were just ecstatic. They were like, how could this happen? Why didn't anybody tell me this before? So those things are, and there are still clients out there that are going through this. Now, Part C, what happens here, Medicare Advantage, is that if you combine all of these, then you can actually they can actually pay anywhere from $0 to $150 to $500, for example, or up to $700, but they can have everything lumped in together, depending upon what kind of medications they are on. Some of these very unique treatment medications that have just come into the market, those medications may not be covered or covered at a discounted rate from their insurance company. So they may end up paying for those kind of drugs quite a bit, and that's why it becomes expensive. Now, Medicare Advantage, very often to most elderly people, it costs nothing. So, and Medicare Advantage, by the way, it is not governed by federal government. This is also managed care. So you find a Medicare Advantage program or plan by Blue Cross or by Aetna or United or Molina, or there are other health insurance companies out there that primarily sell Medicare Advantage plan, but you have to enroll in these Medicare Advantage plan. Now, here's a caveat to all this. If the beneficiary is not paying the Medicare Advantage plan that is coming from Blue Cross, then how is Blue Cross able to provide benefits to this beneficiary? Does anybody have an answer? No? Let me tell you something. So remember I told you that Medicare Part A, if you buy it, you need to pay $450 or something, right? Approximately. I'm giving you an approximate figure there. So every year, by the way, that figure increases. That's why I don't have exact figure for this year. So Medicare Advantage plans are issued by the Blue Cross or by Aetna or all of these, right? So what's happening is that the government is paying the insurance company that $450 that you are entitled to. That's how that is actually. And so the entire push from the federal government is so the entire Medicare program becomes managed care. There are a lot of people still in the traditional or original Medicare. They don't have Medicare Advantage plans. And these are the healthier people, because the sicker, the higher acuity people actually cost quite a bit. So the insurance companies will have a cost up to $1,000 for these people. But because that's by law, they can't charge any more than that to an elderly person. But for the $0 payments to the beneficiary, the insurance company is getting that Part A premium paid to them from the federal government on the behalf of the beneficiary. I hope you guys got that. It is simple that the insurance premium is being paid by the federal government for that person. That's what's happening. So the person is not paying because they are Medicare eligible, but the federal government is paying their premium to the insurance company. Is it clear now?
I think.
Okay. It's interesting. I was like, wow, this world of managed care, it's amazing. But again, the Blue Cross may demand a better care from the providers, and those Blue Cross patients get better care. The Aetna or Molina may not care to that extent what's happening with their patients, so their patients may not get the care from the providers. So that's how we have differences in managed care plans. It depends on who is demanding what and who's managing the plan and who's looking at the compliance measures. Okay.
I have one question about the Part A Medicare. So you said if you only worked for 10 years in this country, then you receive that for free. But if not, you have to pay for it.
Right. So the way it works is it's 40 quarters. 40 quarters meaning there are 4 quarters in 1 year.
Mm-hmm.
So 1 quarter meaning, so you have to work full time for 2,000. It's 1 year full time employment means 2,000 hours in 1 year. So that 500 hours makes up a quarter. Mm-hmm. So your employer actually pays the FICA taxes to the government. But if the employer doesn't pay, or you are self-employed and you don't pay into FICA, then there is no account for that person in that. I know people who have lived in this country for 30 plus years. They ran their own businesses. And guess what? When they came to retirement, they were thinking that they would get that, but they never filed FICA. If they never filed FICA, they won't be able to get Medicare. They can pay into Medicare. They can get it at a cost, which is $450 Part A plus $150 Part B.
Mm-hmm. So let's say if someone was a stay-at-home mom, they didn't work, would they get the Part A, or they have to pay in?
Good question. So if she is a stay-home mom, but the husband worked, so she would be a beneficiary on her husband's behalf. That's a good part about it. She would get the beneficiary benefits. But that's when the husband expires. Otherwise, she would get Medicaid. But it also has to do if the husband. So let's take up a scenario. The couple is about 67 years old, both of them, let's say, and the husband worked and the wife did not work. So the husband will get Medicare, but the wife did not get Medicare because she hasn't worked. So she is eligible for 2 things. Either the husband earns enough to buy her a health insurance, or if the husband doesn't earn enough, the husband has Medicare, but the wife can get Medicaid because now the income is not, the husband has retired and there is not much, they actually fall around 138% of the federal poverty level. So the wife would get Medicaid, but she would have to apply for it. Is that clear? So this is another category actually for people to remain uninsured. Not all people understand that, I can get healthcare coverage. And I have actually come across with women who haven't worked or who don't work, but now they are at an age where the husband may get Medicare. As long as the husband was working, they had employee plans. But the husband retired and the husband is now on Medicare, but the mom actually lost coverage because the Medicare doesn't approve her because she has not worked. So she cannot get the survivor benefits because her husband is alive, or it could vice versa too. The woman would be working and the husband has never worked, and there are situations like that as well. And so in that case as well, the husband or the wife has to go buy the healthcare coverage if they are affluent or if they have the money. But if they don't have the money, they should apply and they are eligible for Medicaid. But very often, because of the health literacy barrier, they do not know it, and they're also reluctant to approach anybody saying that, oh, my income has reduced now, because these people we're wealthy and they have assets. So they can have assets like they can have their own home, and it's a beautiful home, but they also have retirement benefits. And if the husband has a 401k or the retirement benefits, then the wife would be required to buy healthcare coverage, and she would not automatically be eligible for Medicaid. So another barrier comes in where, oh, I don't know, maybe it is going to cost me a lot. So you know what, let's shut up and not even talk to anybody unless I actually, end up in the ER or someplace, God forbid. And that's when I really need it, that's when we'll see what happens. So there are many people that are in that category.
I have a question
with that.
I have a question. So would that situation also work for like older adults who like came here to America and live with their kids? Would the kids then be the beneficiaries on their behalf?
No, actually, it does not work that way. So it works with the spouses, but the survivor benefits, unless the person is disabled, that's when the survivor benefits will kick in.
Okay.
All of these are great questions, guys. You guys are so ready to go out and actually answer questions in the public now. And especially once you have that layer of assets where you know who's where, you can direct people in many different ways. This is good. This is very good. Okay. So I was hoping to end up the session early today, but this is again good. If anybody does not have any questions, then this would be it for tonight, and we would meet on Saturday at 1 p.m. Here. And in fact, if you guys are interested in Saturday and you want to come over to the office to attend the session, by all means, let me know, and we'll make sure that we have the door open, and we have we are able to let you in at the office. Okay. Thank you again. And once again, thank you so much, Dr. Rebecca. Thank you, guys. Moina, how did I do with the Medicare stuff?
You did very good job.
Okay, thank you. Thank you. So you go, this is not my area of expertise here.